Hello, we'll be starting in a few minutes. Hi, David. How are you this evening?
Good, Ellen. Thank you.
Sure. Thanks for being here.
Of course.
I have us up live on YouTube, and I'm going to record the interview. And thank you for being here.
Of course.
There's a little delay, so.
Okay.
All right. I'm Ellen Teeter, Executive Director of the Florida State Oriental Medical Association, and I'm here to interview David Bibby, the FSOMA Legislative Chair, about his work in 2023 and what's coming with the FSOMA bill, which has both a Senate and a House sponsor. David, how many volunteer hours do you think you and your committee logged in 2023 between the titling bill, known as SB 230 in the Senate, which was fortunately vetoed by the governor?
Well, in early spring when we were watching this bill make its way through committee, there was, I'd say, 30 hours a week minimally, effort to, provide attention to identifying the committees of concern that were going to hear the bills, both in the House and the Senate, and to develop a strategy and talking points to enable the membership and the profession at large to communicate their concerns to the chairs of those various committees as well as the sitting members. And it's a challenge it's a daily challenge because things are pivoting and changing all the time, and so the talking points need to evolve at least twice a week. We have provided scripts for telephone conversations, scripts for template letters that can be sent either by email or postal mail. And all of that takes time to draft and coordinate the messaging so that we're speaking with one voice throughout that process, and also being able to adapt our strategy based on what seems to be working from a messaging standpoint, what's getting buy-in from the membership as well as buy-in from the legislators themselves, where they start asking questions and taking a concern. So I'd say minimally 30 hours a week, and that's an ongoing coordination between myself, the executive director, yourself, our communications director, Natalia Morrison, the leadership with the State Association Executive Committee, and then, of course, outside counsel, our attorneys, our government relations people as well that have a hand in shaping that, critiquing that, and then also carrying that message for us. The legislative committee meets regularly once a month, usually for an hour, 2 hours, depending on what's on the agenda. And then we have breakout projects that the committee is working on throughout the year. So last year, things were sort of, all hands on deck with committee weeks and in watching the House and Senate bills progress all the way through to the governor's desk, and then responding once the bill was vetoed. Then we needed to change gears and take the advice that we'd gotten from the Senate leadership and the House leadership for us to be taking a serious look at updating our chapter to avoid finding ourselves in the same position again if a subsequent bill was going to be introduced or any other matter of concern that affects an outdated Practice Act.
Yeah, David, that's a lot of work. Thank you so much.
I
I
mean, I
know
have a
you
lot of
had a
support. You know, a lot of support. We have a robust committee, and the leadership team from FSOMA is always checking in to see what they can do. Your efforts cannot be overstated. Natalia's efforts during those periods of time, we may be communicating and sharing information 3 to 5 times a day with various aspects of the membership, and ramping up and being able to coordinate that in written form, in social media, and all these. It's a tremendous effort. None of it comes easy. So thank you.
Yeah, it can get very intense for sure. Could you share who's been on the committee this year, and a little bit about what tasks they did, because I know they had research they did for you.
Right, right. So one of the tasks that we identified, sort of in the late spring, when there was greater discussion about a concern about our not only definitions for titles, but other aspects of the Practice Act that hadn't been updated since the 1999. And so the committee has about let's say 10 people seated on it. And we have, of course, myself as the chair, and then Galina Rufner, our president, and has an ad hoc position on all of the association's committees where she has input there. But Mercy Gomez, licensed acupuncturist here in Florida, Dr. Mario Garcia, very helpful. I've worked with Dr. Garcia, kicking around other, over the years, going back, more than maybe a dozen years, with different ideas that he's provided input for. Gianna Noth is another acupuncturist that's participating on a couple of committees working with FSOMA. Diana Abrowski is somebody that's come to the legislative committee later in the year, as well as provided some contributions. Christina Casado is both on the board and several committees, but also on legislative, and she has a background in government affairs and lobbying outside of our industry, but in another industry. But she's also a licensed acupuncturist. Dr. Christina Captain, well known in the Florida profession, provided incredible input for ideas for language here in Florida, but also has a good comprehensive understanding of practice of acupuncture in other states. Brianna Jacobs is our student member who's in her final semester, I think, at one of the programs here in Florida, soon to be licensed acupuncturist, but she's been an active volunteer on a number of committees, including legislative. But the primary, once we got through the session and June 1st, when the governor provided his veto, the next task at hand was for us to break into small groups and individually I look at geographically all of the existing practice acts in Florida. I mean, the existing practice acts throughout the country. So some part of the committee took the New England states, the Midwest states, Southeast, Southwest, Northwest, mountains, and out west. And basically what we were looking for is a gap analysis and a compare and contrast with the Florida Practice Act, with anything that seemed novel or outside of what was familiar to us in Florida that we might want to look at in terms of scope of practice. But beyond scope of practice, it was also definitions, terminology, different types of permissions, things that are articulated in statute that are provided authority and definitions. And so anyway, we worked on that for maybe 8 weeks, and I think we met more than maybe twice a month at that period to compare notes on existing language in various states.
Well, what issues primarily do you think this bill is going to solve for us?
Well, I think the primary matter is that the Chapter 457 provides a real skeleton to the Practice Act, in so much as there are things that are provided, like there is a definition for acupuncture, there's a definition for acupuncturist, and I think there's a total of 7 definitions provided in the statute. There's no definition for a scope of practice and no explanation for a scope of practice. Prescriptive authority under the Practice Act is limited to prescriptive authority or prescriptive rights to purchase, possess, and use a Class 2 medical device that's an acupuncture needle and related devices, for example, a TENS unit or something else that might be a prescription use only. And the challenge for us is that without authority and definitions and descriptions for the various things that are created throughout the 25-year history, I say, that things that include, acupuncture injection therapy, which is not just the insertion of an of a hypodermic needle, but also the administration of a prescription-only substance that may be a legend drug that fits into the criteria of herb, homeopathic, or nutritional supplement in sterile form. There's been changes in terms of what is allowed for injectables in the country. There's been a lot of questions about what fits and meets that criteria. And unfortunately, we don't have prescriptive authority to purchase, possess, or own, administer these substances. There's only a rule that says that you can inject it. And one of the curious questions that we had when we were looking at that language with our attorneys is to say, if we don't have prescriptive authority to purchase, prescribe, and possess and administer these products, and we don't have a scope of practice that articulates that we can provide injections in the office, then under what conditions are other healthcare professionals allowed to do this? And so a non-prescribing provider, and examples exist. For example, nursing can inject, basically push on the plunger for an injectable substance, but they are not the person who prescribes it. They're not the person who orders it, and they're not the person supervising that particular procedure. And so it makes sense when you read the rule that was provided by the board, where it says that you can inject something, but you don't have clear authority to provide injections in practice in the scope or to prescribe those products, is that the only way that it would be a legal practice in Florida, absolutely not in a gray area, is if that were a supervised act. And obviously, we're an autonomous provider, and we don't have supervision in any other aspect of our practice. And to not have it clear in the Practice Act is an issue that should be resolved for licensees, as well as for anybody who's receiving that care, that it's clearly within the scope of practice.
And that's been some of the problem with people buying injectables from compounding pharmacies, is they say it's not in your Practice Act, it's just in rule, and that's not enough for us.
Well, that's fair. I mean, they have a responsibility to the pharmacy board, and and to the Department of Health and to the state of Florida, and their guidelines on how, under what conditions they wholesale or supply, sterile injectable products, with an active pharmaceutical ingredient, as it's defined in Florida. They have very strict guidelines for how they need to do that, and so we're not doing ourselves any favor by not making it as clear as possible to our vendors and to within the profession that this is an allowable aspect of practice. Now, certainly the training is there, the competencies are there. We're required to do those things for licensure now, and it'd just be nice if we had the alignment between the language in rule and the language that's in statute. And the reason why that's important is highlighted in what we all just saw last year with titles, is that if the legislature chooses to make any kind of change to definitions and what's allowed, they point to what's existing in the statute. Last year, for example, when we talked about professional titles, the way that this was being introduced was that use of the word physician, in our example, alone, in combination, or in connection with any other word to form a title, constituted the practice of medicine in Florida. Okay. Mm-hmm. And so it's not up to acupuncture to determine what is the practice of medicine. That's what the Board of Medicine does, and the Department of Health does. And so there's any other aspect of, for example, you see a change, or there's concerns. There's a bill that's being introduced this year that's addressing vitamin drip, IV, businesses around the state and the various ways that those businesses are um, founded and who's the medical director and who's running it. Well, one of the aspects of something like that is they might say, injection is the practice of medicine. And so if you're injecting a prescription use only or prescription available only substance, whether it's an office or something that you're prescribing for a patient to take home, that meets the definition of the practice of medicine, well, then it's going to be lost to acupuncturists because we don't practice medicine, we practice acupuncture. These are very clear kind of siloed aspects of practice. The same
and getting it into our statute is the solution for us.
And that's the getting into the statute, then it becomes a concrete aspect of the practice of acupuncture. And there are lots of commonalities that are, procedures and techniques and aspects of practice that are overlapped from profession to profession. But if it's not articulated in your scope of practice or in your practice act somehow, then you don't have authority and possession of that.
And that's, to me, David, that's kind of the same thing. AIT, imaging lab work. There are people out there that have no trouble ordering labs, getting imaging, but yet there are other people we've heard about over the years frequently who the company, their local company, won't let them order labs or imaging.
I mean, by definition, that is the definition of gray practice. You know what I mean? It's where it's shaded more so for one person than another. And it's not something that's necessarily going to become an issue unless you're being disciplined by, maybe another board. We've seen examples where acupuncturists were being disciplined for injection, but they were injecting things that were outside of what was prescribed in the AIT rule. It didn't meet the criteria for herb homeopathic or nutritional supplement in sterile form.
Yeah, there was one guy, I think out of Jacksonville, that was doing Botox.
Examples of that. And I think, there's been other examples where, we've had providers request, declaratory statement to try to clarify what's available and what's not. But, and so, I was asked, and I'm asked from time to time, why are you shining a spotlight on this? We're able to do this and nobody seems to care. So why are we making it stirring the pot on this question? And I would agree that, to a point, I guess I understand that, but it is until it's not. And one of the other, concerns from the profession is if you're being licensed and you're being required to take, spend money, time, effort, and training in providing a skill or a procedure, is that you want to know that it is not a gray area of practice, that it is absolutely in bounds of your scope, and that it is protected for you to be doing that. And that, all aspects of that are protected just from a liability standpoint, from a practical standpoint, and from a licensing standpoint. So this is just one area. I mean, I'd say this is a good example of that, but imaging and lab work sort of fits in the same space. And there's been other questions about things that could be more clear in statute. And what we're really seeking with this is not some expansion of scope. It doesn't exist. What we have is a statute, a practice act that has been dormant. It's on the books, but it hasn't been updated or revised in any way since 1999. And on the other hand, we have rulemaking by the Board of Acupuncture where certain permissions have been defined and expanded, but that are not completely congruent with what's in the Practice Act. And so as those two things grow further apart, then it's like standing on two logs on water there. We're at risk of falling in because if we were challenged by an outside profession or a legislature wants to make a move, we don't have an aspect of the Practice Act where we can point to it and say, no, our authority is provided here and this is where it's protected. And
then we have an example of the legislature stepping in and saying, wait a minute, you have this postgraduate requirement if someone wants to do acupuncture injection. It shouldn't be postgraduate. It's either part of your practice or not, and pretty much made the schools put it into their curriculum instead of it being a prerequisite for licensing rather than a post licensing.
This is a really good example of that, Ellen. You bring up an excellent history. the Department of Health some time ago, and let's say less than 10 years, 7, 8 years ago, we're looking at various practice acts that included certificate aspects of practice. And what the department told the regulatory boards was, we don't want to see this. Something is either in your scope of practice or it's not. In other words, you're not going to expand your scope of practice by using continuing education or a certificate process to bring things into scope. It's either defined in your scope or it's not. Now, AIT, again, has two separate issues. One is the board created the injection rule, and it's as an adjunctive therapy. And it's within the board's purview to provide definitions and to define what is an adjunctive therapy. And if you look in rule, there's a long list of adjunctive therapies, including acupoint injection therapy is defined as an adjunctive therapy. So it was within their purview for them to say, okay, if it's in our scope, then we need to define, what is the training requirement for this and various other aspects of bringing this into marrying the training with the practice. But again, without prescriptive authority to prescribe, purchase, possess, and administer those injectables, it's, the left hand can't work with the right. And so we're trying to bring those two things together so that it's absolutely clear. And there's agreement. This is not a secret. It's something that the Board of Pharmacies have been aware of for a long time. Medicine's been aware of it for a long time. And now, we're working with legislators to align the language between statute and rule. And they understand this is not unique to acupuncture. It happens with boards of medicine and regulatory boards, frequently. And so there has to be a pause point where then you bring those two things back together. So we have a reset and everybody understands, okay, all of these things fit under that umbrella and you can pursue them.
Yeah, I have a question, excuse me, about the federally, it's illegal for us to inject homeopathic at this point because the FDA has ruled that those companies need to do more to get them approved. So they're not approved for use. I know some people get them, but it's not legal. But the issue with AIT for a lot of people has been other things that are or have been used that the compounding pharmacies kind of have said, no, we're pulling back. It's not clear to us you can do this. So this statute or bill that we're proposing would fix it so that the compounding pharmacies would then feel more comfortable selling to us.
Well, yeah, because they need to substantiate if they're audited or questioned about that, they have to do their due diligence about who they're supplying prescription use only products to. And so they'd be able to say, we went to chapter 457, we looked under prescriptive rights, and it's defined and described there, and it provides a satisfaction that they've done their due diligence, but it also meets the criteria under Florida law for them to do that.
Yeah. Okay. What hurdles kind of have you prepared for in this campaign? Kind of how did you go about preparing? What do you think could happen or could impede it? And then are there hurdles you didn't expect you've seen come up so far?
Thank you. I would say, starting in August, the legislative committee had gathered the various data points from other practice acts and things that we wanted to lay over 457 to say, based on our training, knowledge, skills, and ability, all of these things belong within the scope. And if we look at what's available elsewhere in the country, we're all basically trained and have the same knowledge and skills. So we shouldn't have areas of practice in one place and not in another. So we were trying to create some uniform language around that. And in the end, the role of the legislative committee was to make a recommendation to the executive committee and the full board for FSOMA to say, these are the various aspects of practice that we see elsewhere. Here are examples of language that we think would improve our own statute. And these are the things that we think are deficient in 457, given the time span between when the Practice Act was passed and erected and in our current time and situation. And so we provided all of that language, and working with our attorneys came up with, what would be the ideal way to restructure 457, both from a construction standpoint and also to make it from a logic standpoint. It has to have a certain logic to how that flows. And they had their recommendations back to us with sample language for that prior to the conference in August, and we were able to meet as a group and go over that language in detail and ratify that again among the committee. Made its recommendation to the EC and the board based on our attorneys and government relations people's input, and come up with what we think were working language for us to move forward with creating a draft for a bill, and a bill that would go to the House and a separate bill that would go to the Senate. So there was a fair amount of forethought in each and every aspect of the change that we thought was necessary to solve the various problems that we were just discussing, but also without going into too much detail, because there are a couple of other smaller things that we did that we thought would be enhancements for the Florida profession. For example, under continuing education, we didn't increase the hours. The 30 hours that are required for renewal remain the same, but we created a new definition for a practice management CEU category. One of the challenges to the profession, I think, for a lot of people that are especially in private practice, is that we don't have an opportunity for personal development or continuing education in areas of practice management. It's required under existing language that all of the training that we have for continuing education is on clinical aspects. And so, like I say, these are things that we had worked on. And there are a couple of other wrinkles to our statute that need to be looked at, like out-of-state teachers when they're here to help support us with doing live demonstrations. How do we work that in so that it has an exemption, and an exemption to the practice of acupuncture in Florida? Things like this that we were able to accomplish. So there are the central things we're talking about scope and definitions and titles. These are the primary areas of concern. Qualifications for education is another area of aspect that is an important one for us to consider, because areas of autonomous practice, things that are usually supervised, like evaluation and management for patients, providing prescriptive authority for injections with no supervision, ordering and using diagnostic imaging and lab work. These are skills and aspects of scope that, if you look at other professions, only those with a doctoral degree provide supervision. They have direct access for prescriptive authorities. They practice in an unsupervised manner. And so this was another area that if we want to provide authority and protection for these things as a matter of scope of practice, we also thought that it made sense that the qualifications for training were included a doctoral. And most of the thinking on this question, came from studying and examining how is it, for example, other non-physicians, chiropractors, physical therapists, occupational therapists, audiologists, optometrists, how is it that they finish a doctoral program within the same 4-year time frame that the statute requires acupuncturists to do that, and yet we're terminating with a master's? How can we use our time more efficiently to look at examples of entry-level doctoral programs and say, how is this being done? How is it that a chiropractor is graduating with a doctoral degree and acupuncturists are not, when you look at the time commitment and the amount of hours required? And one of the things that is a standout is that all of the professions, doctoral and physician and non-physician, except for chiropractors and optometrists in Florida, all of them are required to earn a bachelor's degree prior to matriculating into the graduate program.
Wow, yeah.
Chiropractors and optometrists are required to get 90 hours. not a bachelor's, 90 hours. So again, we ask ourselves, how is it that the requirement for 90 hours is met and you still terminate with a doctoral program? And so we started, investigating, talking to the accrediting bodies that accredit those entry-level doctoral programs. And, they made it clear. They said, most of the master's programs, especially those that are here in Florida, have their hourly requirement and their competency requirement exceeds the minimum standard for the master's program by many credits and hundreds of hours. And so when I asked, well, how is it that we've got 21 out of the 50 schools in the country that have an entry-level doctorate, how do they do that without crippling their programs? And the answer is 95% or close to that of the course material that's needed to complete the entry-level doctorate is embedded in the doctoral program. And so they create a dual program where they complete the master's and they finish with the doctorate. And what is not exactly, but basically the same amount of time that it would take if somebody did a doctorate completion program. And so by increasing the entry-level requirement to 90 hours, we take 30 credit hours out of the master's program. All right. And so we finish with an extra 2 semesters of work to do the 5 competencies that are required for the doctoral program. And so the discussion about, does this make sense? How are we going to do this? How much of a challenge is this to do? We started the discussions with the schools in the fall, and then really started having more frequent and earnest discussions with them about these changes closer to Christmas and into the new year, because we can't make those decisions for the schools. Everybody is at a slightly different starting point. Some of the programs have already looked very closely at what those requirements are. But it's certainly from a student standpoint, from a professional standpoint, when we look at providers who are allowed to provide supervision, who themselves are not supervised, they're most practicing at the doctoral level, even if it's an entry-level doctorate. The physical therapy profession transitioned into an entry-level doctorate without having to deconstruct their whole education. Chiropractors did it in the 70s. Optometrists have been doing it for 2 decades or more. Audiology has been doing it for 2 decades or more. And now we see that the nursing profession is looking, the master's program that they've had for many years, that was the entry-level training for nurse practitioners, is going to a doctorate as part of their 2025 nurse practitioner effort to bring that to a doctoral level, as well as PAs right now. And PAs are looking at, they practice at a master's level, but they're revamping and looking at a doctoral completion. Again, for various aspects of autonomy, scope of practice, highest standards available, and what's expected of a diagnosing and treating practitioner.
Just want to confirm, the only thing that this changes is in terms of training and education would be at a future date, anyone licensed after that date will have to meet different requirements than currently.
That's correct. So this, we've seen examples of this even within our own profession, where the qualifications for licensure were increased by the Board of Acupuncture through rulemaking, not as part of the change to the statute, where in 2012, if I'm correct, they added the 4th board for herbal medicine as a requirement for licensure. Now that when the effective date for that in 2012 only applied to prospective licensees. In other words, people who were being licensed on or after that effective date. And so anybody who was licensed prior to that is not subject to the same requirement to continue use of their license or to renew licensure. It only applies to those that are prospective. And again, I just circle back on this question of the qualifications for licensure moving from the master's to the doctorate only requires an additional 16 credit hours, which is about 250 hours in the classroom. And there's a slight increase on clinical hours as well. Competencies are different. Faculty requirements are different. Cost is different. Time is a little bit longer. It's not like they're exactly the same, But when you look at the totality of what is in the MSOM program, and you look at what's in the Doctor of Acupuncture and Herbal Medicine program, they're more than 90% similar in terms of didactic and clinical requirements. And so it is a change. It's improper to say it's not a change, but it is a relatively straightforward change. And we think that the timing is necessary. And if we're asking for more authority in our practice, then we need to be able to, for the people that are granting us those privileges, like in the legislature, you need to point to say, well, what are you doing to earn that? We're saying, well, we want to, protect the public, use the highest, standards of education and training we can, and maintain, superior licensure. And if I answer the question,
this is something you may not know the answer to, but it seems like if you've got a program that is like, now it's sort of like people get a bachelor's and then the master's while they're in school. In the future, they may then be getting, actually, if they have 90 hours, they'd get a bachelor, a master's, and then the DACM, the doctoral level.
Yeah, in our example.
Would the teachers, if you're teaching a entry-level class or a medium-level class, would you have to have a PhD, a doctorate? Or could
my understanding
you do a
on
master's?
that, and I'd leave this to the ACOM and the schools and the administrators to really finalize, but I think it's the concept here is that if you're teaching at a doctoral level program, it's something that you're earning credit hours for a doctoral level element, is that needs to be taught by somebody who has achieved at least an entry-level doctorate. And so it's sort of like that person can teach programs that are all the way down to an associate's, but it doesn't work the other way up. And so when you're looking at the full faculty, you'll have those that are on faculty that are teaching that are on par with their education and training, those qualifications for those hours, and whether it's later in the program or some area of a doctoral element that's woven into the curriculum sooner or later in that process, you'd have somebody who has completed their education at or at least above that level.
Well, it's good that there's, 42% now of APs have doctor levels?
I'd say it's certainly over 30. We looked at the MIT, Massachusetts Institute of Technology Media Lab, had great data that we were able to use with the legislature last year that showed something like in the last 6 years, nearly 1 in 3 degrees awarded in acupuncture were at the doctorate level. That's happening outside of Florida at this time, but certainly we have our own advanced doctoral program here in the state at Atlantic, and hopefully we'll have more soon. And
right, and I hear of plenty of people that are taking programs, PCOM programs or whatever in Florida.
They're available in Texas and Colorado, out west, up north, and that's how and mostly available online. The other thing I think in conclusion with this is that the conversations with the colleges and programs, there has to be some understanding, at least from our part, that a timeline that makes sense both from an accrediting standpoint, a financial standpoint, a planning standpoint, that all of those things are taken into consideration. And this is not something that's going to happen overnight. We need to deal with the concepts and the areas of practice that need to be codified and provided for in the statute. That has to be done in the near term. But these changes with regard to the qualifications for licensure, at this point, are more than 10 years away. And in some aspect, and there's still some flexibility about, providing additional time for that. This is not something that is trying to be rushed or hurried in terms of implementing it. We're working with them closely to try to at least understand that we're in agreement that this is something that would be a benefit to the profession. There's some discussion and discord about that as to whether or not it is helpful. We're going to continue that discussion, but implementing it, even if we're able to introduce our bill, make these changes that we want in terms of protecting areas of practice, any implementation for qualification for licensure would come, I would say, after 30, 35. And that would be provided in the language that's adopted this year. It's just that it needs to be, it's a concept that's part of the bill. We're asking for a lot. And in return for that, we need to demonstrate that we're serious about being autonomous, diagnosing and treating practitioners. And this is sort of the carrot that goes with that.
Yeah. Well,
And
to me, our medicine is a full system of medicine. We have treatments for all sorts of things, and all sorts of conditions, and can really help with improving people's health, handling stress, improving digestion, sleep, reducing inflammation, if you want to use a Western term.
Yep.
Making people's bodies more comfortable and happy. So I think, we deserve to be independent practitioners practicing our medicine, not
I
getting
agree.
into other things. So,
And I think that's what, that's an aspirational part of this, but that's also an expectation. When we're talking with legislators and other, regulators from the department, they're looking at us and saying, you people are the subject matter experts in this area. You need to take control and domain of your medicine if you want to have, the final word on what is and what is not acupuncture. And so, we're dependent in some ways, in many ways, on the, creativity or the innovation in education and in the accrediting of that to move the profession, to advance the profession forward. It can't all be done sort of on the professional side. And so,
right.
how do we do that? We drive academic standards. We include evidence-based and evidence-informed care. We train people to work in interdisciplinary settings, different healthcare settings, so that they are employable, and we can take the best educated, most qualified people in our practice, in our profession going forward, after 2035, after 2040, to see greater integration in other healthcare systems, so that we're not limited to just being practitioners or therapists with a modality where we're needling.
Yeah.
We want to be
And
able to carry.
if we're not in Medicare getting paid,
No.
someone else will be paid for doing some little piece of our medicine.
That's
And
a
the
challenge.
true power of our medicine will never be seen.
Right. We want to keep our arms around this, and only, I think, is somebody with the full training and passion and understanding for our medicine can advocate for that and say, yes, we can, insert and manipulate a needle for a therapeutic effect. Yes, that's part of what we do, but that alone ignores, 90% of other aspects of our medical practice. And if we're just treating for pain and pain conditions alone, then all of what's available through women's health, internal medicine, all the many things that are part of a full system of medicine, they're not appreciated, they're not elevated. And, like I say, we want to be practicing and participating at the same level as other non-physicians. We need to make sure that we're advancing the profession so that that's attainable, that's reasonable, and it can be done sometime,
We can
on a
get somebody
timeline.
that knows Li4 for headaches and can help with quite a few headaches, and they will take the jobs. And when we know
we've seen
all the
that.
variations that could happen, that we can treat much more effectively with the full approach. That's very.
I agree. There's too much of that. Too much of that has already happened in the last 10 years.
Yeah.
And so at some point we need, to make sure that the things that we're already trained and educated to do, that we can continue to do them with authority and elevate and advance the profession at the same time.
I'm going to go off topic just a little, because there's two campaigns I've been involved with over the years with FSOMA. One was, we lost PIP, and that was 10 years ago now.
Yeah.
And I went up there. We had one acupuncturist from Lake City brought his patient, and that was powerful. And we moved the needle enough so that Senator he was from South Florida. He got on the floor of the Senate and said, well, we found out we were wrong. The acupuncturists weren't a cost factor in PIP, but we want just emergency treatments for PIP.
Right.
So acupuncture's still out. And it's like, oh,
I know. It's a good
educating
example.
them about the power. We now have ER studies that can show that,
Yeah.
that we could help with pain, we can help avoid opioids. And that's the topic to bring, because that's on people's minds, is
Yeah.
opioids and the epidemic. But we're so much more than that. And then the other was the, dry needling. And we did sue the Board of PT. I went to the very first meeting where they had it on the agenda. And we said, look, you've got to have us speak if you're going to talk about this. And they, ooh. So then we had several meetings. I went to several. There was a big one in Orlando, I think you were at, that we invited a lot of local APs to come. And they still passed the rule, but we sued them and won. So we blocked it for a while.
Yeah.
Now they had powerful friends and got into
Well,
the legislature.
there's a good example though. The aspect of that the acupuncture profession prevailed in, the area that we had won in, was that the board had acted inappropriately to expand the scope of practice for physical therapy to include acupuncture, which is beyond the mandate of any regulatory board. Their mandate is to protect the public, and when necessary to provide rule promulgation to interpret existing rule language and statute, but they can't create,
and the statute said no penetration of the skin.
Correct.
So
and so
yeah.
we had a very technical and a very legal argument, but there was no winning. The broad stroke of that was that they're saying, look, we have years of training in managing diseases of rehabilitative medicine. This is a strategy that we want to incorporate. It's largely known to be safe and effective. We would argue that it's safe and effective with appropriate training, but just the same, there's not a lot of data to support that acupuncture is dangerous no matter who does it. So, when you get, they have the authority, they have the degree, doctors standing up and saying, look, this is our medicine. We're defining what our medicine is, and we're saying that it includes this procedure. And, the legislature at the time was more than willing to support them, because what does it do? It expands access to safe and effective care. And there's no argument that that's a good thing for Floridians.
Right.
And so this is why we see this, in other areas of practice. It's the same argument, whether it another profession, if they want to pursue doing the same. And so
and the Speaker of the House pretty much told us, if you do anything to mess up this bill next year, I will make sure personally it goes through without any input from you. So,
well, we worked very closely with the bill's
political power.
Right. We worked very closely with the bill's sponsor for the physical therapists. And at the time, the physical therapists, were in the room with us. And we saying, we had concerns about, hours of training. We wanted there to be some sort of reporting mechanism for adverse events and injuries. And so in the end, we're not going to prevent them from defining what is their medicine. And, they had to agree that they're not practicing acupuncture. They can't, title themselves as anything to do with Chinese medicine or acupuncture. And they're happy with that because they want to perform dry needling. But they also needed to complete twice the hours that they were originally looking for training to perform dry needling. Right. And there's now an adverse record-keeping process that's reported to the president of the Senate and the Speaker of the House. I say annually or every other year. It's maintained. So sure enough, there was a new Thorax last year that came out of that profession and that needed to be disclosed to the legislature. This is, part of the discussion that we were having with them prior to licensure, but you can only provide so much input. Ultimately we want to have ultimate say in determining what is the practice of acupuncture in the state of Florida. I say we, meaning the profession. And we're not going to take kindly to a lot of outside influence saying that this aspect of your practice is really the practice of medicine or the practice of physical therapy. We can decide for ourselves. The scope is really the contours, the four corners of the scope is based on the entry-level training. And so as the entry-level training it innovates, changes, and adapts and includes additional types of training, then so too the scope may follow. But that's the direction. We can't change the scope without entry-level training to demonstrate that we have competencies, knowledge, skills, ability, training under clinical supervised conditions to assert that it is safe and effective, to be performed on the general public in Florida.
Yep. I want to say one more thing. February 22nd is Acupuncture Education Day. Between now and then, there's going to be some committee hearings. So if you get an email saying you live in an important district and, the committee chair is your House of Representative or your senator, please take a little time to participate.
This is so important. We're going to try to identify key legislators based on their district. And if, your legislator is sitting on a committee of concern, meaning they're going to specifically hear the bill, then, providing them input and asking for their support and giving them reasons why they should support you as a small business owner, you as a vital healthcare provider in your community. This is the opportunity to do that. And they're going to hear from other people. They're going to hear from other professions. They're going to hear from other outside, influences that are looking at this language, but they need to hear from us and understand how meaningful and significant it is, and how their support is really going to help elevate the standards of care in their community, access and options for people to have safe and effective healthcare.
And we encourage you, if you're not a member of FSOMA, please join. If we have a powerful, effective organization for the profession, it can only improve your practice, your scope, and your business. So check it out. We are getting a new website, so don't judge us on the current one. But we've been working for 20 years or more for the state and for the profession.
Right. I was just going to say, and lastly, I said, there are a number of stakeholders. There's, a lot of people feel like they're being, affected by the language that's being contemplated. The association is committed to continuing to work with every stakeholder to find, a reasonable way to make sure that everybody's needs are met in this. We're not trying to turn over an apple cart here and make things harder on anybody, whether it's a practitioner, a student, one of the programs. We're going to use all of the time and all of this strategy that we can to make sure that everybody's heard, their input is valued, and we come up with what is, the strongest solution for all involved.
Yeah, I'll be posting the video from last night shortly, but we also have this to help people know what's going on. So,
thank you, Ellen.
Thank you so much, David, for taking time out of your day.
No, my pleasure. Thank you, everybody. Thank you for your support.
All right.